Alright, so we've got these 4 pins in the leg. The reason we have these is because the camera for the robot, which is right up there, has to be able to see the leg at all times. We can see the femoral and the tibial component are within the view of the camera. So this screen, not actually there, this is the augmented reality that I can utilize, so I have a much bigger screen than that small screen over there. So this is our foot pedal. This is the robotic probe. So anything this touches is where it's going to collect the point. So this is a checkpoint on the femur and a checkpoint on the tibia. These are points that do not move throughout the surgery. This big screen. We're going to teach about the ankle, the medial and lateral malleolus here, the center of the ACL footprint right here, and then the center of the knee, which is right there. Range of motion of the hip. So collect all these points, yep, and the knee straight, and then show it the knee range of motion. So I'm going to trace the outside of it, and as I do, a 3-dimensional model appears, and then if I take my foot off the pedal, it tells me the blue areas are areas I have to collect. It's areas the computer needs in order to know exactly where the femur is. And then I think the most important part is the posterior condyles back here, because this is what articulates. This is what's touching the tibia when you've got the knee bent in athletic positions. So now I'm doing the same thing on the tibia as we did on the femur. I'm collecting all the blue spots that the computer needs in order to be able to map it out. So now what we're going to do is test your ligament balance. So a varus knee means the medial side is tight, you're bone on bone medially. That means the MCL, the medial ligament, should be tighter, it's kind of scarred down, and the lateral collateral ligament on the outside should be looser. So medial is the orange, lateral is the purple. So we should see, this is a 0 bar, we should see that the orange line is either shorter or maybe even below the 0 line. Let's see what happens. That's a pretty standard varus knee right there. The orange line is tight and below the 0 line, and the purple line is above it. And then we'll test it a little past 90 degrees. So we know when the knee is straight and we know when the knee is bent what the ligaments are doing. And these bars usually don't look the exact same, but you can see it's similar. The orange line is tighter in both. All right. So that was us testing the ligaments. Now what we're going to do is change the position of the implant to match the ligaments. This is telling us we have an 8-degree flexion contracture. That means the knee doesn't straighten out all the way, and we want it to be perfectly straight. And we'll correct for that. So now I'm going to change the implants. This is a little bit above what I can kind of explain quickly. Okay, so what I'm looking for is for the orange line to be tighter than the purple line, purple bar. That's a normal knee. A kinematic knee should be tighter. It just shouldn't be as tight as your knee came. 2 clicks of distal femur, which will be another millimeter of distal femur, and that'll help straighten the knee out. Let's start with this. All right, good. So that's our robotic plan. So now we've mapped the knee, we've planned the knee. The last thing we have to do is execute it. So we're going to verify that our checkpoints haven't moved, make sure nothing's changed, because we don't want to start resecting bone and find out that something changed and now we're cutting the bone all wrong. So that's just a safety checkpoint right there, which is a great idea. All right, so purple means there's a lot of bone. Blue means there's about 2 millimeters. Green, less than 1 millimeter. We want everything to be white. This has these, this is the burr. The burr is right there. It comes out of its shell as we get closer to bone. Then I press on the orange pedal, and that's what helps resect the bone. So it's designed to help me not over resect bone. But essentially I'm just resecting what we planned using this burr. And it's incredibly accurate. So now we already set the rotation. So this is our rotational hole. You'll see how that comes into play. So that was the lateral femoral condyle. Now we're going to come over to the medial side and do the same thing. Get this bone here. So we made those little holes there. What I'm going to do is take this and deepen the holes. So there's 2 cuts in the front. 1, 2. There's a cut in the back. There's one on each side. And then there's these diagonal cuts. You just have to go on either side of that block. This thing in the middle. So the saw is going to go through here just to kind of debulk it. And so the orange line is where that saucer is, telling me where the cut plane is going to be. And I want that to match up with the purple line, which is what we planned for. And this is kind of our preliminary cut. This used to be the most accurate cut you could do, but we're going to come back with the burr. We're going to come back with the burr and make sure that it's actually accurate. And usually I end up taking just a little bit more bone. This is the medial meniscus here. It's an important structure in a native knee, but once your knee is replaced, this is just something that can get pinched and cause pain. All right, so now I got to get the meniscus on the outside over here. This is why we had to make all those extra cuts, because there's a lot of cuts. So this is not so much a replacement as a resurfacing, or we're basically, let me come on off, basically capping the bone. This is a circular reamer. Gets out the majority chip. This little chip fits right in the middle, and that completes our femur trowel. So here's our tibia trowel. This is a trowel plastic insert. That's the part that can wear out in a knee. We put this in there. We planned for a 10 millimeter insert, and that fits in perfectly. So we had it at 8 degrees. Now we're at 0, right? So that's fully straight. That's great. In terms of flexion, maybe move that thing up so you can see it. 145. You'll never, this patient will never keep that much, but gosh, they might be able to get 130 plus. Let's go to the next screen. Oh yeah, collect this. All right. That's what we're looking for. All kind of less than 1 millimeter of movement. That's perfect, especially with these trials that can shift a little bit. That's a beautifully balanced knee. We don't want it tight. We don't want it super loose. We want anything less than 2 millimeters, and this is actually less than 1. So that's a perfectly balanced knee. That's exactly what we're aiming for every time.